For our new members, may not be as familiar as some of the members that have been around of my roundtables that I like to do. Normally, I will do a roundtable, and it will be an all-day ordeal, or even 2 days. And this was a topic that I felt needed to have some discussion to do several things. Is one, kind of give more information, I think, to a lot of our members that may not be familiar with it. I know that some folks are big supporters of rate parity, and you know, some of the issues I see with it is it's bigger than a number. It's a lot more complex than just a number or a matter of saying we're going to pay the same as something else. I also have concerns, and you know, we have those discussions off and on, that to me it's an issue I believe belongs between the contracting company and the providers. But I wanted to have the people on both sides of this issue today here with us, and we're going to let them kind of talk amongst themselves. We do not do testimony. We just have a conversation, and it, you know, could be a debate between both sides, but that's what helps us get information out to us. So I don't know who would like to start this discussion. Sunny, can I put you on the spot? Or I can put Jennifer on the spot. She raised her hand, Sunny. You're off.
Oh, well, thank you.
All right. Welcome, Jennifer Finley with the Kansas Hospital Association.
Hi, I'm Jennifer Finley with the Kansas Hospital Association, and I'll just open by kind of setting the stage for those that are here representing the provider community and some of the conversations that we've had. As many of you know, there are lots of challenges facing our rural healthcare providers today, and we've been engaged in a lot of conversations with many of you during this session about those challenges. We have small communities that are struggling to make sure that access is continually provided to the residents of those communities. And we believe that every Kansan deserves access to equal healthcare services regardless of where they live, the kind of transportation that they have available to them, or the kinds of jobs that they're employed in. Technology has changed the way that we deliver healthcare, and patient expectations over time have changed. But what we haven't changed is payment and delivery models along the way. And we've spent a lot of time this session talking about the need for innovation and the way to address some of these challenges innovatively. And we think that telemedicine is just one of those tools that we can keep in our toolbox to help make sure that access to patients is available in all parts of our state. We just wrapped up a series of conversations across the state, 6 regional conversations about the challenges facing rural healthcare. And in every single one of those conversations, the need for telemedicine and access to telemedicine services was raised by community members participating in those dialogues. This has become clear to us that this is something that Kansans expect to have available to them. With that said, though, we really do value that relationship between patients and their primary health provider. We're not trying to get in the way of that. We want to provide a system that augments that relationship. We want to make sure that Kansas physicians are on the front lines and continuing to work with our local communities. We just know that there are some situations and some conditions where telemedicine is an effective tool and can even result in improved outcomes for the patient. We recognize that there are costs associated with delivering telemedicine services, just like in-person care, and we want to make sure that providers are paid fairly for those services. The pandemic has really given us an opportunity to see the power of telemedicine. They have introduced some of these concepts, but we need to learn a lot more. We know that patients now want telemedicine services. A recent poll told us that 90% of them want this to continue to be an option, but there are things that we don't really know. And so what we are suggesting is that we spend some time to really gather some data, to analyze the situation, and to figure out what's going to work best for our state. We don't know how often telemedicine will be used on a regular basis. We don't know what the true costs of those services look like and what the impact of all of this will be on the total cost of care. But we like an opportunity to do a measured, reasonable study of the situation so that we can all come to the table and then come up with some reasonable options for the future. We know there's a solution out there, and we really want to work with everyone to find that reasonable approach. So we thank you for opening this discussion today, for allowing us to come to the table, and we want everyone to know that we're a willing partner in this conversation.
All right, thank you. I appreciate that, and I like the idea of hearing that we're willing to have conversations. That's great. Who else would like to speak at this time? This is a matter of you raise your hand. When you're ready to speak, you speak. You're not waiting on me to call you. All right, Sonny, I'm looking at you. You're in my line of sight.
Good afternoon, and thank you, Madam Chairwoman. I can tell you that Blue Cross and Blue Shield of Kansas has been a strong supporter of telemedicine since the early 90s. It is critical in our state, especially with having so many rural and frontier counties, that we provide our members with the ability to connect with their providers, specialty providers, as well as their primary care providers and mid-levels, to serve them and meet them where they are. One of our concerns, though, has been this dramatic push for telemedicine payment parity during the COVID pandemic. Blue Cross and Blue Shield of Kansas voluntarily increased its payments for telemedicine during the pandemic, and we started this back in March of 2020 because we understood that many of our offices were not even able to open and see patients in person. So we did that as a way to amend and help these providers who were literally not able to make their payroll for their employees. We wanted them to be able to pay for their brick and mortar sites and to help them out during the pandemic, as well as encourage those that maybe had not used telemedicine in the past to go ahead and adopt and use some type of telemedicine platform so they connect with their members and their patients. What we have seen, though, is that telemedicine was embraced very quickly back in March, April, and May of last year. May actually was our high point for using telemedicine. One of the interesting things, though, is that we are seeing the majority of the claims that are coming in are related to telebehavioral health. And we also understand just how important that is in our state. We were surprised that we were not seeing a lot of other services being performed. And when we did see those services, some of them, quite frankly, are questionable and happening safely and thoroughly in a telemedicine manner. So we understand that during the times that we are dealing with right now, which really feels like war times, that we are trying to modify and allow these different procedures to be done at payment parity to accommodate everyone during the pandemic. But we also understand that this is a very different situation that we will be in, hopefully, a year from now. And it's not the best time to say we're going to start a study right now and start looking at doing telemedicine payment parity permanently and to codify something without us returning to our new normal. We are supportive of paying providers the fair market rate, but we also, at Blue Cross and Blue Shield of Kansas, like the ability to direct and try to pay those providers who are doing God's work out in Western Kansas and in rural areas. We want to be able to encourage and incentivize them to see people in their offices. And we just believe that moving forward with payment parity right now will actually discourage and perhaps incentivize more providers to continue to not see patients in person. And we don't want to move in that direction at this time. Thank you.
Who else? All right, we'll go to Jennifer, right? Or Michelle? Michelle, I'm sorry. She's got Kyle Kessler's name in front of her. And then we'll come over to Claudia. Is that right? Okay.
Hi, Michelle Ponce.
And feel free to take off your mask if you are comfortable.
I don't think you'll hear me very well
Okay.
with it on. Michelle Ponce. I am with the Association of Community Mental Health Centers of Kansas. We represent all 26 licensed mental health centers across the state. I really appreciate and agree with many of the comments that both Jennifer and Sunny made already. Telehealth has been a tool used by behavioral health for over 2 decades, and it will continue to be an important service delivery option into the future. During the pandemic, it really became a necessity to ensure safety and well-being of both our patients and our staff. As Sunny mentioned, about last spring, March and April, it became the primary service delivery option for our consumers, when in fact most of the mental health centers closed down completely, and other than for certain crisis services and medication management. From that experience, we did ask our members for their feedback on how that worked, and several themes emerged. Some of those were that telehealth actually helped overcome barriers such as lack of transportation or childcare or time missed from work and school that will continue to be barriers into the future, whether we're in the midst of a pandemic or not. Telehealth also helps patients overcome anxiety and other limiting health conditions to more successfully engage in the therapeutic process. We heard about individuals with chronic health conditions who are unable sometimes to get out of their home and into the four walls of the community mental health center. We also heard of patients who opened up to their therapists because they felt safe in their home environment and being able to receive treatment in that space. And lastly, telehealth has also helped to ensure consistency of treatment for patients who move frequently, such as our youth in foster care who may have unstable housing or placements. Ultimately, our primary point is that the patient and the provider should have the choice as to the best and most appropriate service delivery mechanism for their particular situations. For some, that may mean returning to face-to-face services. For some, that's going to mean ongoing telehealth.
All right, next I have Claudia, and then I'll have Stuart Little.
Thank you, Madam Chair. Claudia Tucker, I'm Senior Vice President of Government Affairs and Public Policy for Teledoc Health. That's a telemedicine company that's based in Dallas, and we operate in all 50 states. And I just want to tell you a little bit about why I'm here. I think that we've got a unique perspective because we do go and talk to policymakers in all 50 states. Our focus here and our footprint here in Kansas is strong. We cover 350,000 lives here in the state. In 2020, we did 20,000 consults. We cover, well, there's 4,500 employers that offer our benefit. And last year in this state, we brought $13 million worth of savings to the state, the employers, but most importantly, the citizens here. Our physicians are Kansas licensed docs treating Kansas patients. We're a technology company that focuses on the delivery of health care. As I said, all 50 states, 175 countries. And just want to kind of tell you why I'm here, because nobody probably knows me. I talk a little bit differently than y'all do, but glad to answer any questions. Look forward to the conversation.
Stuart Little, and then we'll go to Rochelle. You can, will that not come down to the table, that mic?
Let's give it a shot.
There we go.
I wanted the authority to stand up, but I'll...
Yeah, he's used to doing that.
Thank you, Madam Chair. Stuart Little, I'm here today on behalf of the Community Care Network of Kansas, the FQHCs, the Behavioral Health Association, who do substance use disorder behavioral health services, and the Kansas chapter of the American Academy of Pediatrics, so interested primarily in behavioral health issues and primary care. And a couple of points that I wanted to just kind of put out, and I appreciate you, Madam Chair, for arranging this conversation. I think this is a valuable opportunity where, rather than us emailing each other and having conversations, to kind of talk here and get some ideas out. A couple points I wanted to make. First of all, I think all the members on the committee got a packet of information which included a real useful survey from the United Methodist Health Ministry Fund, a provider survey, and a consumer survey, and that shows the kind of levels of satisfaction with telemedicine. I want to make just a couple of points here, and first, and keep kind of making the tie back to the payment issue. For providers and consumers, which is something we haven't really mentioned or talked about, is that the benefits that they've seen in telemedicine are obvious. Those of you in your personal lives and your family lives have seen the benefits of what telemedicine can do, and that in the behavioral health side, Michelle's right. We're seeing new people. We're seeing people come back into care. We're seeing people that could never get to treatment through telemedicine. Those benefits are all there. So I think about it when I talk to the folks I work with in terms of the questions that come up from the provider side is that if we're not getting something near the same rate, why would we do it? And our costs are actually higher. That seems to be part of the conversation that we have with folks on the provider side. And why that, and the reasons are the same reason you have a new staff person sitting here at the table and a couple of $1 million of technology into your room, because everything is different and we've all have had to cope with that. So all of your overhead's still here, plus you've added a new cost related to doing the work that you do. That's the same thing that everybody else is having to do. But not only that, you've got to maintain the same delivery system that you had before, the in-person system with everything, but you have all those variances that come over the course of time. With folks, you've got to have new people set up a call, somebody to follow up and make sure that they know who to call, some more IT people. All of those things are on top of keeping your office open. Now, Sunny, a description of, peaking in May and making reference to, we need a year. This may not be the best time to do a study. We've got to return back to normal. I think from the data that I've seen, and we certainly don't see on the provider side any of the data from the industry, is that there's been a leveling off. And I think if you look at Medicaid, and you brought the Medicaid folks in, there's a leveling off. There's been a drop from that May peak. And I don't know if we're at that new normal, but it seems like we're certainly headed to new normal, because we've kind of filtered out at this point who can go back in to in-person, who still needs telephonic, and who that helps. The point that I would suggest here is that, particularly for you all as policymakers, I think there's obvious. I think both Jennifer and Sunny mentioned that at what point does the market have its ability to come to some determination of what should be done, but consumers and providers have an expectation that telemedicine and having access is part of what their healthcare system involves now. And that consumers say, we like this as an option. This is something that we would like to see continued. The providers say, if that's what the consumers want and that's what helps us provide care, we need to have adequate funding from the rates to continue that. And so we can talk about waiting and it's not clear and those kinds of things, and I get that, but there's an expectation among everybody that tele is something that if you can use it, and that benefits everyone. But I think there's also an expectation that the costs are higher, or not the higher. They are at the same, near the same, and sometimes they can be higher. But it's folks that have experienced telemedicine at this point, it's an option that people want to keep. And if you want the providers that serve your communities to keep doing that, we need to come some kind of recognition where there's comparable payment so we can keep doing it, because that's what people want now.
All right, and then I've got Rochelle, and then I'll have Dr. Newland. Is that right? I couldn't see if that was a W or a V. Rochelle.
Thank you, Madam Chair and members of the committee. I'm Rochelle Colombo, the Executive Director of the Kansas Medical Society. And I do appreciate, I can't see the chair, but I know you can hear me. Hello. Thank you for putting this together. This is a really, I think, important subject, but it is complicated. And as you all know, the underlying bill that came before you earlier in the year really had to do with some of the more basic structure that had to deal with telehealth and not with this subject. And I'm looking at my name tag and it says rate parity. And there's different terms that we've talked about and that everyone is, I think, using as we begin this conversation. There's rate parity, there's pay parity. These can apply to things like the reimbursement rate between facility and provider, between the same service for different providers. There's a whole lot of ways that this conversation breaks out, and it really is complicated, and it's important. I think it was either 2015 or 2016 that a bill came before this committee that created the structure, which right now is lifted because of COVID, but it was the first time that the legislature put regulations in place regarding telemedicine. And before that, it was just unregulated. You could use it. It was a delivery model, but there wasn't structure that encouraged any sort of reimbursement, really, honestly. And there was a recognition about 5 or 6 years ago that this was something that was now available. This was a delivery model. And to be honest, part of that discussion was the insurers they have kind of, I call them captive, but they have their own platforms. They have Teladoc or Amwell or different ways that they could provide telemedicine because it was a new tool that was, I think, consumer friendly and that people wanted. And one of the concerns was it wasn't equitable for providers who were living here and did have brick and mortar to figure out how to kind of compete against the insurers who had these own platforms. And that was one of the things that was intended to be addressed in that original legislation a couple of years ago, which was to say, you know what, if we're going to do telemedicine, we need to have the rules around what are the platforms, what is required, and who can access it, because we at least have to make sure that if an insurer can provide that platform, that so can a physician that's already here, that they can treat their patients that way too. And so what I would tell you is we haven't really revisited that because, of course, no one was planning for the pandemic, but here we are. And I think Stuart makes a good point. Obviously, the world has changed fast, and we've figured out how to provide what was necessary in the time. And telemedicine was undoubtedly, I know you've heard lots of statistics, and we'll hear more about how heavily this was utilized, particularly in the early spring months when, out of a desire to preserve PPE and to make sure there wasn't increased exposure, physicians were doing as much care as they could, and that varies across specialties, as they could by telemedicine. But I will tell you, as the individual who represents all specialties in Kansas, that there's a wide variety of feelings about telemedicine and whether or not everyone supports having that tool, and it's good for patients and it's good for providers in certain circumstances. But there is certainly not a desire to see telemedicine undermine or replace in-person care. And so this conversation about reimbursement is really, really critical, because how that's reimbursed, it has to address these things about how do you make it something that a physician can afford to offer and should offer in the right circumstances without also undermining in-person care. And that's going to be complicated. And there's some ways that can be done. And I think it's appropriate to note, yes, the insurers did come to the table and have been reimbursing this during the pandemic. And so there's a desire to see that continue. Some have said we're not yet in the new normal. I don't know that we will know when that is, but I'll tell you, physicians are generally back to providing in-person care. So there's different times and ways, again, that telemedicine is utilized. It depends. Are you rural? Is it a follow-up visit? Do you have the option for in-person care? And so we need to make sure that providers can compete, I think, out of fairness. And we have sat around tables before and talked about these things. If telemedicine is a tool that insurers are going to provide to their customers, we want to make sure that the physicians on the ground can also compete in that sphere at the right way so that they can offer those same services with the same rules. And we've got to make sure that that's reimbursed in a commensurate way. But we also want to make sure that we're looking at all of those different things: facilities, providers, the type of visit, is by providing the same reimbursement, the same for a telemedicine visit versus in-person care, going to create a situation where in some instances there will be a move towards a predominantly telemedicine environment. And we just don't want to see one take over the other. And so what I would tell you is we think this is a really important conversation. It's a complicated one. I think a lot of the right people are around the table. And we've had a minute, I think, to maybe catch our breath from COVID and go, okay, we made it through the worst part. And now we need to figure out which things move forward. And the Medical Society has put together a task force. We hope to work with insurers and with other providers to continue this conversation and look at how it breaks out, because I think that hasty movement could result in unintended consequences that would be irrevocable for potentially for rural health. And that's true if it's unreimbursed at the wrong rate or if it's reimbursed at the same rate. It's just not very simple. And so we really do want to be a part of that conversation and provide feedback from all specialties and from all parts of the state, because it's just not as simple as saying we support rate parity or pay parity or we don't. We don't have a position at this time. We do want to study it. And I would say this one piece, with no disrespect to my colleague to the right, that we have to do the study now. If we wait till new normal, then another new normal is on the horizon. We need to be looking at not only what is the utilization, but assuming that we don't continue on in a pandemic state forever. How do we want to get that balance right? Because this is, COVID is with us. And just like with the technologies and the things that we utilize in different places, whether it's school or the legislature or work, those technologies aren't going to go away. But we have to figure out what the balance is between in-person gatherings, care and treatment, and then the technological tools that we have. And so we would like to be a part of that and provide data where we can. And thank you.
Next, I have Dr. Newland, and then it'll be Brandon Peppard on the WebEx.
Appreciate being here. This is not my usual world. The last time I was in this building was a 7th grader as a page. Could not find the legislator who asked me to find some bill. And I spent most of my time trying to relocate that person. I'm a practicing pediatrician in Wichita, and I'm a part of Ascension Medical Group, and come from maybe that lens of a primary care physician with relationships with patients, trying to see where this fits into that model. And my introduction to telemedicine, really the very first time as I think back, was when a patient came to me for a well visit, a child with asthma, and it became apparent that they had been treated a few times for asthma flare-ups through a tele-approach to somebody, I don't know where they were from. And as I looked at it and realized I didn't have a chance to recognize that, even be aware of it, and therefore modify their chronic disease management plan to address it. And so their asthma was out of control because it was being episodically treated, and the primary care relationship wasn't all it could be. So my focus, part of it, is an awareness that primary care and in reality many specialists who have ongoing relationships with chronic disease management need the opportunity to be in that connecting loop with their patients regularly. And when they are, I think the total cost of care actually is less. And I think our payers are saying that telemedicine can offer ways to have the total cost of care be less because they're offering it. I think if you combine the modality with a relationship with a physician who knows the patient well, all of that together can create a situation where total cost of care can be less, not more. And so in some ways, I'm a little confused on why this is as challenging as it is. In reality, before the pandemic, I'm not sure, but I've never been aware of us being able to receive payment for telemedicine services. So this did have the big surge, but we have gone down after the release of the shelter at home, more PPE becoming available, towards probably no more than a couple of percent, 2 to 3% of our total visits in our large primary care and multi-specialty organizations. So it really is the physicians and the patients together deciding what's the right situation, the right setting to have the patient get the care by the right person at the right time. And I think all those things can happen, and this can be one more tool in the tool belt. But like anything, it has to be at least focused parity in payment in a way that makes it sustainable long-term for a practice to include it in their tools that they are offering to their patients. So that's kind of the lens I'm coming from. Focused parity, a way that helps total cost of care and keeps the relationship between the patient and their chronic disease manager, their specialist, or their primary care strong, as that does support good care. Thank you.
All right. And then I'm going to go to Brandon Pepper. And anybody that wants to speak, just raise your hand and make sure that John sees it over here because he writes it on a notepad for me. So,
Madam Chair, thank you for the opportunity to participate in this discussion today. I do appreciate it. I will underscore that health insurance providers are supportive of the appropriate use of telehealth to provide access and reduce cost for our members. And that's been talked about a bit. And I think someone mentioned we do need to maintain focus on consumers because they're not necessarily part of this conversation, and they really do need to be. We know there's been a huge increase in utilization because of the pandemic. And by and large, that's been a very good thing. And one of the points that I've heard repeated is that providers had no way to provide services during the pandemic in person, and that's correct. And so carriers agreed to payment parity because there was no other way to offer services, at least during the initial stages. Now, I've also heard a couple of people say we're returning to normal, and we are, and that's a good thing. But I don't think everyone is comfortable going to an in-person visit yet. So we are not at a return to normal at this point. I've also heard costs are the same, but the fact is that for a telehealth visit, they're not generally the same level of intensity, nor do they require the same amount of time, nor the same equipment as an in-person visit. And we're being asked to subsidize bricks and mortar for telehealth services. And I don't think that's appropriate. Madam Chair, you started this dialogue by saying you have a preference to allow the private parties to negotiate. And I think that's appropriate. And maybe payment rates should be higher, but maybe not. And I don't know the answer to that. I don't negotiate provider rates, but I would say it's a desired service. There's no question about that. And so where there's a desired service, the two sides will come to an agreed price point. And we've also heard, I've heard in other states that providers will not provide this service unless they get payment parity. And we know that's not true either. We know that when there is no requirement that payment parity be met, providers do negotiate a rate. Once again, maybe a new equilibrium will be found because we have this experience with the pandemic and the closures of doctors' offices. And we know people liked access through telehealth. And so with that increased desire on the part of the consumer, there'll be pressure to make sure that the service is widely available. So I think before we head too far down the path of having the state determine what an appropriate price is, we need to determine if there really is a problem first. So I think, you don't want testimony, you want responses to questions. And so I'll be respectful of that. And I'll just say, once again, we're supportive of the appropriate use of telehealth. It's not appropriate for all things, but where it helps our consumers get access to care, we absolutely think it should be an available modality. So I'll stop there, and I'm happy to answer any questions.
All right, next I have Dr. Latimer.
Thank you. My name is Dr. Scott Latimer. I'm a family physician and the Chief Medical Director for Sunflower Health Plan. I'm here today to represent the MCOs under the state Medicaid plan. And I guess the first thing I'll say is that all of the MCOs are supportive of telehealth. We all saw the same thing, that there was a tremendous shift from in-person care to telehealth. It's the same story that everyone else has been saying today. It was a clear, dramatic change. We've monitored member satisfaction with services. They're very positive about this. So overall, I just wanted to say in the beginning, telehealth has gone from being a small piece of the medical ecosystem to being a much larger piece in the last year, and will likely continue. I don't know how much, but certainly it's become much more mainstream. I know that we're here to talk about payment parity. I'll mention one of the things that's not payment parity that the MCOs are working with KDHE about, and that is the span of telehealth. Some hands-on services, such as physical therapy, occupational therapy, may not really be ideal for telehealth. It may be a secondary in quality to a hands-on physical visit. So just be aware, telehealth is complex. So there are issues about appropriateness of service in certain settings, very appropriate in some, not clear as appropriate in others. Last thing I'll say is that most of our reimbursement there's a fair amount of restriction by the state. We don't negotiate a whole lot. There's a floor on where we can go, unlike private insurers. But that being said, I guess I would say, just from looking at how the system works in general, I would suggest just caution about legislation that puts a floor in reimbursement. It's just concern about medical inflation, which everyone worries about all day long. But it's just one to be very thoughtful about. At what point is the value of of that kind of legislation offset by inflationary pressures when there's not a lot of resources out there. Thank you.
All right, next I've got Connie Freese.
Hi, I'm with the Blue Cross Blue Shield of Kansas City, and we, like the other carriers here, have been very supportive of telehealth. As a matter of fact, I think it was probably 10 years ago when a new business model came to fruition, and that was Teladoc and Amwell, who provided telehealth services with a unique cost structure. Their sales to us was, we can offer telehealth services 24/7. We can do them at a lower price point than providers that have brick and mortar, have staff, have other costs. So when they came to us, we adopted that and we put it in our health plans. We offered it to all of our members. It was an efficient way of delivering that service. We didn't have a lot of uptake. There were people that said, no, I want to go see my doctor. And we did everything to try to encourage, not everything to try to encourage it, but we made it less co-payment, but people were resistant to that type of technology. People wanted to see their doctors. Then the pandemic happens. And immediately, our Amwell Teladocs, they were all staffed for this. They were able to provide services as offices closed. The demand was incredible for telehealth services. This bill will cause me to have to pay a provider who is willing and has a cost structure that is less than other doctors who are, have different cost structures. They're willing to provide this service for a less price. Who wins? I got so many consumers that are on high deductible plans. They shop. They know if they do telehealth through Teladoc or Amwell or whomever, that they're paying for it, not the insurance company. They've got a $1,500 deductible, and they know if I do telehealth, instead of an in-office visit or ER or urgent care, it's going to cost me less. This bill would tell that consumer, no, we need to charge you more because there are certain players in the market that can't deliver telehealth at the cost that others can, and we're going to subsidize those. I agree with Brandon, and we need, this is like a solution in search of a problem. We need to slow down as physicians and consumers get more comfortable going in the offices. You're going to see providers who have traditionally not done telehealth, you will see that it'll go down. They want patients to come in their office. They want to be able to do a urine test. They want to be able to do a lab, listen to the heart. I think we are running to fix the problem, increase costs, and it's just not necessary. So, happy to answer any questions.
All right, Jennifer Finley.
I'm hearing a lot of talk about rushing into things, and I don't think anything that we have suggested is that we rush into a solution. I think what we've suggested is we take some time to understand the situation with a small measured test of certain conditions or certain situations and see how it works. But I'm also really concerned about just leaving this up to market forces. In Kansas, we have 122 hospitals, and of those, 91 are small rural facilities. They're not part of systems. They don't have negotiation power, and they often have no power to negotiate rates. They have to take what the insurance company gives them and just accept it if they want to participate with that payer. So I think we need to provide these small rural providers with some assistance in leveling the playing field. And again, we're not trying to mandate that this be something offered for every condition, for every patient, for every situation. We're wanting to look at certain situations and see if it can provide some benefit. You've heard a lot about chronic conditions and how maintaining contact with patients on a regular basis can provide benefit. We have preliminary evidence that shows through a project that the KU Care Collaborative has been running that when you manage those conditions appropriately, you can reduce the overall cost of care by 30%. That's some significant savings, as well as overall way better outcomes for the patient. So I'm struggling to understand why we wouldn't want to make those kinds of services available to all Kansans in order to help them better manage those conditions.
Representative Eppley.
I just want to make a few comments for the group today, only because we've got so many fantastic folks here at the, I guess, the tea table or round table. And I just think this is an opportunity. I view this as 3 stages. It was in 17 when we passed out the telehealth bill and we got it done. So that was stage 1. Then we had the pandemic come. That's stage 2. And soon we're going to be in stage 3. And I'm looking forward to that when we're post-pandemic. You know, this is an opportunity for those of you in this room at this table to help us come to grips with this. I would much rather that you help us figure this out than that we figure this out for you. This is so important to me as a physician. The comments, and I am close with Rochelle, but the comments that Ms. Colombo made about looking to physicians to help guide this is really important, because we understand. I mean, I get it. We can go too far with telehealth or we cannot go enough. And there's a sweet spot in there in the post-pandemic stage, and I don't know where that is. And I appreciate the physician who commented that it's pretty simple, but it really is very complicated, I think, because of the variety of providers, the types of services. It's going to take a lot of work. And I'm suggesting to all of you here, I mean, we have both. We have providers, we have payers, and we have a conglomeration of folks in between. And it's really important that a task force approach or whatever, that we man up and try to get this done. We need to look at a way in the post-pandemic stage, in stage 3, that we allow telehealth to continue to grow and flourish in the state of Kansas. If we go back strictly to market forces, I'm afraid that telehealth is going to diminish to the point that it won't be a viable option for a lot of patients. And yet, on the other hand, as a provider, I don't want to default to Teladoc and to Amwell. I just, that's not my agenda here today. I think it's important that we honor our patients, we honor that their desire for service, and we need to look to that, and that will drive this at some point. I understand, for not picking on a generation, millennials really want convenience. They want it quick and on their phone, or on their pad or whatever, their iPad, and we want to be able to provide that in certain situations. But I think we've got to sit down together and figure this out. Or at some point, I really think the legislature will have to take this on as a project to figure this out. And I don't know, I don't think it's going to be as good as what you all can put together if you'll just work together sitting down at the table. Now, I hate to, I'm not here to give timelines, and that's why we have the smart chairwoman, but I think that we need to look at getting this done sooner than later, and I don't think this can be done in a matter of a week or 2, but I think it needs to get done, and it needs to get looked at and move forward. So thank you, Chairwoman.
Are there other comments from our folks here? Dr. Newland.
Sorry about that, Madam Chairwoman. I appreciate. I think if there is a policy or a direction that would come out of a task force or out of this body, as a practicing physician, having something that's predictable will be very valuable. In other words, if I don't know, I have to look at their insurance to figure out whether or not I can do a televisit, and I have to look up online or go to a book to discover whether it's even an option or not, which is kind of the world we were in before the pandemic. It's just not going to get used when it really would be an effective tool. So I think some consistency, and maybe that's why the idea of having it where it's not negotiated with each individual payer and by each individual clinic or each individual rate becomes chaos in many ways. And I think there is value in predictability from the physician provider's perspective.
Representative Kelly.
Thank you, Madam Chair. And I appreciate everyone coming together here. It was in 17, I was involved in the telehealth bill and all. And last year, early in the year, I know that I was frustrated because it wasn't going anyplace. And I asked the then Medicaid director what it was going to take to get it going, and little did I know the next month it'd be a pandemic that would get it going. But I agree with the good representative from Atchison, the good doctor, that it would be good if it can be worked out by everyone on your side of the table, because I think back to the old saying is that an elephant is a mouse built to government specifications. So I think you end up with that. If you can do it yourself, you might actually end up with a mouse, and it's workable and not something that's an elephant and cumbersome. So I would urge this to happen, and I'd urge it to happen now. Just, I think we are headed to phase 3, and I think if we don't do it, we'll end up back to where we were when I asked the question, what's it going to take to get telehealth really going and used properly? And so I do encourage this.
Representative Blex.
Thank you, Madam Chair. I also thank all the groups that give us this expertise. I think one thing that's really important that I hear from is the patients and the convenience. I would hate to see us lose ground that we've unfortunately gathered over the pandemic and training people. People are still afraid to come to the doctor's office, and they're going to be that way. I go to a church that I affectionately call them cave Christians. We're online. They haven't been to church since last March. And I think, we see a big decline. And if we lose, I know in my rural environment, a lot of the rural patients really appreciate not having to truck 50 miles to come into a provider for something that may be relatively routine. So I would hate to see us lose what this pandemic has taught us, because if we stall out, I have to agree with Representative Kelly, if we stall out, then we're going to lose a lot of momentum, and people are going to get it off the mind. They're not, and we're going to lose that. So we need to get going on it, in my opinion. Thank you.
Stuart Little.
Yeah, I just want to add one brief comment about that in terms of folks losing this. I think one of the underlying issues, particularly for a lot of us in the behavioral health field, is the access to care that expanded with telemedicine becoming more widely used and available. The distance for folks to go to treatment, the complexity of family life, and how do you leave your kids and who watches your kids, and the capacity to do that. People who had not been to treatment before, people who had been in treatment and left for any variety of issues. This was an opportunity for people to come back and to access behavioral health services. And I think, without regard to, I just say that's something that we stand at high risk of losing if the capacity and ability for providers to continue to provide those services, that's going to have an impact. And I think everybody in this room on this health committee is well aware of what we're seeing in the behavioral health world coming out of the pandemic as well.
Representative Parker, and then I have Brandon Peppard next.
Thank you, Madam Chair. I would also echo the comments of Representative Kelly, and to that end, I appreciate bringing everyone together in this format, but I know this is a topic that folks have been talking about before today as well, and in the spirit of finding something workable, I'm just wondering if in those conversations and meetings before, those of you who represent providers, hospitals, et cetera, have there been compromises offered? What do those look like? What would it look like to pick one of those up and move forward?
Jennifer, you want to answer that? All right.
I would like to answer that. The Hospital Association has put forward a proposal that the provider community has discussed and thinks is a good first step. We've come to the table and we're ready to talk about it.
Go ahead.
Is it possible to hit? Oh, thank you. Madam Chair, would you like this shared with the committee in some way? I can make sure. Perfect. Thank you. Thank you, Madam Chair.
All right, Brandon Peppard.
So once again, Madam Chair, I want to commend you on engaging in this discussion in this way. Not every state has done it this way, and so I think this should be productive for you. A couple of additional thoughts I had while I was listening to the other commentary. someone at the very beginning mentioned that the need for us to continue to innovate, and that's absolutely correct and appropriate. A thought occurred to me, however, which is that payment parity, if it was imposed through legislation, would potentially stifle innovative payment practices. And by that, I mean value-based care. And so I think, without getting into too much detail on that, I think it's important for that to be a consideration for all of you and for everyone else who's in the room there as this conversation continues. How to achieve what everyone wants, which is to continue to encourage the appropriate use of telehealth without stifling other innovations. A couple of other thoughts just about the consumer. There was an NGA report recently that included the perspective that there are efficiencies in telehealth, making it a lower cost service, and that requiring payment parity misses an opportunity to lower costs. And lower costs are directly good for the consumer. And so I think that that's just another thing I'd like to leave you with. Thank you.
Rochelle Colombo, and then Claudia, did I see your hand up too? Okay, let's do Rochelle. Yours wasn't up? You lied to me? Okay, Claudia, and then, Michelle, it was Michelle, never mind. Okay, Michelle first and then Claudia. He had the R and the M messed up.
Thank you. I just wanted to make two more very short points. One, I don't often utter the phrase silver lining of the pandemic, but one of the silver linings of the pandemic has been the ability to really invest some of these recovery funds in upgrading technology, both within our community mental health centers and even being able to provide some of that technology to our patients, which has really increased our capacity to provide telehealth and to provide it very well. Second, I know it's not news to anyone on this committee that the behavioral health system is really suffering from a workforce shortage, and we are challenged in terms of finding and retaining licensed professional staff. Telehealth allows us to augment our workforce, as well as we're coming out of the pandemic, and some of our professional staff, our licensed clinical therapists, such, have gotten accustomed to being able to provide telehealth. There are some of those that we have heard anecdotally may not be comfortable coming back into the office, and we are at risk of losing them if telehealth is not something they're able to continue to provide.
Connie? Oh, I meant Claudia and then Connie. My left hand over here is not doing a good job today, but he usually does. Go ahead, Claudia.
Thank you, Madam Chair. Couple of thoughts. As we all know, people don't get sick always between 9 and 5 and Monday through Friday. They get sick at night, they get sick on the weekends, and usually their PCP's office is closed, if they do have a PCP. An average of 40% of the people in this country do not have a PCP. If you look at the younger demographic, that number goes up. If you do have a PCP, the average wait time to get an appointment in the U.S. is 21 days. So you're either going to get better on your own, or you're going to get a lot sicker, and you're going to go to the emergency room, which is the most expensive place you can get care. Telehealth has a value. It's just not about, it's not just about the savings, it's about the convenience. If you're a wage earner, if you're working at an hourly wage and you've got to take 2 hours off to go to the doctor's office, that could be your electric bill. The idea that you could access quality health care with a Kansas licensed physician from either your workplace or your home has value. There is never, ever going to be a time where telemedicine will supplant going to see your doctor in person. Telemedicine doesn't fix a broken arm. It doesn't fix a heart attack. It doesn't fix a lot of chronic conditions, but it is there and it does have value. And the idea that we as Teladoc should be made to accept the same reimbursement as a physician who has the overhead of bricks and mortar is ludicrous. And as I talk to people, our average consult is $49. The average for an in-person is about 175. The idea that we would be forced to take 175 when that's not what we want to do, that's not what our business model is, we don't have to do that. And the only people it's hurting are those patients. I completely agree with the gentleman back here. I live in rural Virginia. And so we're hurting our patients, and usually we're hurting the people who need it the most. Thank you.
Connie?
So I just totally agree with everything you said. Prior to the pandemic, we have always paid a physician who's doing telehealth the same as being in network. Inpatient. You just didn't have providers that were doing it. That wasn't their business model. So, and I don't think we have any plans of not continuing to do that, because we're going to see it drop back, and people are either going to have a telehealth or inpatient. I don't see us dropping off. What's going to happen, though, is Teladoc is willing to provide that service for $49. And if the legislature says, no, we've got to have a minimum payment and we're going to force that on you, now I have to pay them more than I'm currently paying them. And I just don't understand that. I don't understand a Republican state who would, mandate business models that are fine with what we're willing, two sophisticated contractors who are willing to accept and do a deal, and the legislature says, no, we are going to force you to charge more so that our Kansas residents will pay more for that visit. It doesn't make any sense to me.
Rochelle?
You just called on me early, Madam Chair. I hadn't yet come up with my question, but I do have a question based on that. And I just want to make sure I understand. So prior to pandemic and even prior to the legislation passed in 2017, like you said, telehealth was available, but we didn't have regulations around it. And you're saying that it was reimbursed as the same, is it okay for me to ask a question? It was reimbursed at the same rate as in-person care.
So if you sent me a 99213, place of service 02, same rate.
Was that dependent upon using a platform that was approved by Blue Cross Blue
Nope.
Shield Kansas
Any
City?
claims, if any provider would have sent a 99213, 211, whatever.
Is
and
that
say,
a code?
Yeah, that's an evaluation and management code. That's your normal standard office visit. And instead of saying, what's place of service, is it, what's in the office? 11. So instead of, I would know that was a telehealth visit. I don't penalize you. I don't do anything. I pay you the same rate. So, and that's how I imagine most carriers were doing it, because there wasn't, these providers weren't doing that service. It wasn't worth coming up with a whole new fee schedule for where there was little utilization. I had a different fee schedule for Teladoc. I paid them $49 and they billed me a different code. So I guess that's what I'm saying is, like, we are trying to fix something that's not a problem, and it can only increase the costs to my consumers, to your constituents. And you are already getting an in-person rate. You're just requiring that I pay a different platform more money, and my consumers pay it. So,
But to that point, just again, I want to make sure that, because we're kind of in the weeds, and I think for everyone here, but including non-practitioners, what you're saying, though, is that for a provider that was in network, they got the same rate for telemedicine as they got for in-person care, but is it correct that that was a different rate than what was paid to Teladoc?
yes.
Okay, so I think that's an important part of this, and that is exactly what I was talking about in my underlying statement, is that there might have been the same rate for an in-network provider, whether they did in-person care or telemedicine, but it was not the same contracted rate as that in-house telemedicine provider. And that's where you're finding local providers were not able to compete then with the insurance-provided telemedicine option. And then to build and have that...
No, they were competing.
Well, let me just finish, if I might. To have the infrastructure necessary and to have the platforms that are required for them to invest in those things to provide those services to consumers has a cost. And if it's not reimbursed at the same rate as a different telemedicine provider, even though it's the same rate they would get for in-person care, it's non-competitive. And that's where I would say that this is complicated. It isn't as quite as straightforward. It's not as linear as I think. And there's different ways that breaks out. And I'm not assigning any value to that. I'm just saying it's an aspect of it and a reason why there are a variety of, I think, opinions. You know, when we use the word provider, that is not just a physician, that's not just a facility, that's any level of healthcare provider. And all of these things are reimbursed at different rates based on their contractual agreements with insurers and their location. And so I just think it's a little bit more complicated than some of the conversation that's been around.
So I would just say, though, we never required any of our providers to use any kind of platform. My primary care doc, she sits at home in her office and her kids are running around in the background. She's on her computer, just a computer. And she's billing 99211 with place of service too. And I pay her the or my company pays her the in-person rate. So we don't require platforms or, you know, it's got to be HIPAA compliant or whatever for privacy concerns, but we don't send our providers and say you have to contract with Teladoc if you want to provide telehealth. Two different models, sir.
All right, I've got Sunny, then Claudia, and then Brandon Peppert.
Thank you, Madam Chair. This feels a little bit like we're moving towards a single payer system. And I really want to get us back to understanding what the differences may be and why it is sometimes confusing. And that is because we are in a free market and we do have negotiations between insurance companies and providers. It's very different for a hospital than it is for a provider that's in a brick and mortar office by themselves or maybe in a larger group practice. At Blue Cross and Blue Shield of Kansas, we do use American Well, Amwell for telemedicine services, but we also allow our in-network providers to perform telemedicine services as well. And they can use any platform, as Connie was saying with Blue Cross of Kansas City. It's never been restricted, but what sometimes people forget is that we have also self-funded groups in this state, large employers, and now, because of the price of healthcare, many small employers even, who have carved themselves out of the fully insured insurance market. And what they're doing that for is to try to lower their cost and overhead. They are trying to make sure they can be good stewards of their employees by providing them health care benefits, but they've taken it out of the state and the insurance market in the state and are building their platforms following federal laws. And at the federal level, right now, I can say that Medicare is reimbursing telemedicine in payment parity, but they have already, CMS has already notified providers that they will be changing that post the pandemic to go back to their traditional payment structure. I am not suggesting that in any such way, but what I want to point out is that, again, we have different partners here that we have to work with. And doing something on the fully insured side does not mean it's going to happen on the self-funded side. And if anything, it's going to drive more people towards the self-funded market so they can carve themselves out. What we often hear at Blue Cross of Kansas is that many self-funded plans do want to carve out and only use a telemedicine platform like American Well. They don't want to partner with our local providers, and we are encouraging them to do that because we know the importance of that continuity of care that you were mentioning earlier. And we are really excited to know that our providers that are in-state can see our people in person if they have a chronic condition. And in those situations, we also work closely with our in-network providers to build accountable care organizations and value-based programs. When we start rate setting and reimbursement setting, it takes away our ability to create these unique programs that will help providers and patients in certain communities. And that's where I find that this is a little bit more complex and is troublesome to even legislate a study on this, because it takes away our ability to recognize that there's a need to treat a certain type of condition and incentivize providers to treat that condition in person. And also other cases where we may want to incentivize providers to use more telemedicine and telehealth. So we today already provide an additional reimbursement for our rural providers, those brick and mortar rural sites that we have, versus what's in more of your urban centers like Topeka and Wichita. And that's because, again, we're trying to encourage them to have those brick and mortar locations. But to set a set reimbursement takes us away from that flexibility and creates this model where we're now paying a lot more for services and not necessarily paying the relative value unit that's assigned. I'm sure the physicians in the room understand RVUs and relative value units. They are not the same for telemedicine services as they are for in-person services. And I do think we need to talk about this and work together and study this, but I don't think it's something that we can legislate the model for, because it needs to have the ability to be flexible and look at different components of this. And that, again, is something that cannot really be done right now. It needs to happen when we're outside of the public health emergency. Thank you.
All right, and then I've got Claudia and then Brandon Peppard.
Madam Chair, there was some conversation about platforms and mandating a platform, and I completely agree. I don't think we ever want to mandate a certain platform be used. There's been a few bills that have been introduced nationally, and that's exactly what they're doing. They say you cannot mandate a health plan to use a certain platform. So that's good. And as far as the infrastructure costs that a physician practice would have to take on in order to do telemedicine, we being Teladoc, we lease our platforms to hospital systems and physician practices, so we do that. There's also off-the-shelf programs that the doctor's offices can purchase to help them as they build this out. We firmly believe that if a physician provides a service, they should be compensated for that service. However, my husband and I farm for a living when I'm not doing this. When we have to invest in technology or get a new tractor, we have to suck that up. We don't pass it on to our client. That's what we have to do so that we can compete. Thank you.
Brandon Peppard?
Yeah, I actually think that Sonny covered a lot of what I was intending to say. And though I like to hear myself speak, I'll just say that the previous conversation really argues for why these discussions about payment rates need to be left to negotiation.
Representative Carlson, and then we'll come back to Claudia.
Thank you, Madam Chair. I always put things so much simpler because I can't do the complicated things, but saving Kansans money. So I have Blue Cross and Blue Shield through the state, and I pay my copay when I did my telemedicine with my specialist here in Topeka from Clay Center. I paid the same copay. So I didn't pay $49. I paid $60. So I'm just confused on why that, you know, so you're doing it for $49 and I'm paying $60. What's going on? Thank you, Madam Chair.
Well, and I think that's where, you know, when we talk about the complexity of this issue, because you can have that same discussion in the world of pharmaceuticals. Do I go in and use my health insurance prescription plan, or do I pull up RX, good RX, and just pay out of pocket? You know, first of all, things aren't even Steven, and I think going back to where, you know, the thing that Sonny was talking about is, you know, people forget about the fact that not all insurance companies in Kansas are created equal. Your self-insureds, totally different ballgame, and I believe those, and I haven't been on the insurance committee in years. ERISA's, is that right? So guess who doesn't control them? Anybody know the answer to that one?
I'm sorry, I should have directed it to Connie, but it was more about the Blue Cross Blue Shield, and I guess not straight across the board. Sorry.
Well, nothing is. That's what my point is, Representative. It's not, and there's probably not a way for doing that because of the contractual negotiations that goes on in the world of insurance with our providers, whether it's in property and casualty, whether it's in you know, in the health arena. But I know that the largest school district in the state of Kansas is self-insured, and they do a smaller copay for telehealth. They're encouraging their people to do telehealth. And that has nothing to do with, with the Blue Cross Blue Shield and Aetna and any of the other big insurance companies that are actually controlled by the Insurance Commissioner of Kansas.
So can I
Claudia?
answer her question? Oh, sorry.
Oh,
No, I think she wants you.
one of you.
So I think where you got the $49
Oh, I bet Connie.
was.
I screwed that up.
I think where you got the $49 was when Claudia said that's an average, $49. We're not going to get into pricing and what it is with your plan or whatever. So when she threw that number out there, that's an average nationwide that Teladoc charges. So not sure for your specific situation. It didn't sound like you used Teladoc, right? You used your specialist. The other thing I want to bring up is I think it's important for everyone to understand, I haven't had one provider group, whether it's a health system or an independent physician's office, come to Blue Cross and say, we need to be paid more for telehealth. The reason is I'm paying them the same as in person. There is, until there is a real issue in the commercial market, give us at least a year to hear from providers who are upset because they're not getting paid the same. You're trying to fix them. They're not complaining. And what's happening is going to raise the costs over here. That doesn't make sense. So, bring me a provider group who says that Blue Cross of Kansas City is not paying me the in-network fee schedule for a telehealth, and then let's try to fix something.
I think one of the things that we've been hearing is that we may have insurance entities out there that are already sending letters to providers and saying, okay, we may be changing the rates, as the pandemic winds down, et cetera.
Okay.
And, from my perspective, not only as a legislator, but also as a consumer and a business person, I'm thinking, that really creates some uncertainty out there. And I can see why all these providers would be nervous about that, because what are they going to tell their clients when they have to say, no, we can't do this any longer? So I think that that's part of why the discussion of rate parity has started coming to a head right now, because we know that we operated under a pandemic, under a totally different thing. I think one of the best things that we saw in Kansas was to see the insurance industry and our health providers industry come together and just get the job done. But now we've got to go back to the table. If you go back to what Representative Epley was talking about, is that we've had the 3 phases. So you've got phase 1 was the 2017 of designing what does telehealth look like in Kansas. Phase 2, the pandemic, which we're still in today. And then post-pandemic, which is tomorrow. And we need to start addressing what tomorrow looks like. But in that process of getting to tomorrow, I would hope that there's not major, changes to where we just yank a rug out from underneath individuals as we do this. And we're going to run up against the meeting deadline here. And I just wanted to kind of summarize up some things. And if I'm wrong on this, somebody speak up, or if something needs to be added to this, please let me know. Is, first of all, I see that everyone in this room is in agreement that telehealth should continue. I don't see any shaking nose of heads. And telehealth is a tool that increases access. Telehealth should also be, and now this is in my opinion, and it's a discussion everybody's got to have, I believe it should be more economical. I think telehealth, I think it's very, very important that anything we do with telehealth, it does not replace the in-person visits. And I go back and I think about one time, having dinner with my physician, and I said, I get really tired of it. You think I have to come in all the time. Why can't I just call you? This is pre-pandemic. And he says, Brenda, because I like to touch you. And I'm like, this doesn't sound good. And he says, I hear things, or I'll feel something. We're not paying attention to that. They're using the stethoscope. We're not hearing what's going on. We're not seeing what's in our ears. They may detect something that had not a darn thing to do with what we came in with. I came in with a cough, but all of a sudden he finds something he doesn't like. So I think those things are important, that we don't lose that. You know, I have and I'm for those of you that don't know my background, I do not have a background at all in mental health or in the health provider world, but I have a passion for mental health and telehealth, mental health. I have some concerns with it. I don't want to see it that way all the time. I think there's questions that get brought up. Is telehealth the best way for us to provide services for juveniles? There's a lot of reasons that you want to have that juvenile in that room with you as a mental health provider, because you want to know who's in that room with that juvenile so that they're not being coached. I think that if that's the only way that we can get the services, then definitely we do them. But we can't lose that in-person, you know, personal touch. And I don't believe that our healthcare providers would want to see that happen either, because I think that they know what the ramifications are. You know, I actually had a friend of mine that ended up making an emergency run because an appendicitis just wasn't caught with a telehealth visit. Nobody's fault. It just happened. All right. But had they been in there, would that doctor have caught it? Probably, and caught it early on. What services should not be provided via telehealth? And, you know, that was a question that actually came up in this committee when we were talking about some of the telehealth bill that we had before us, is you're thinking, okay, and I think someone mentioned earlier physical therapy, and that actually got brought up in the committee. I'm thinking, how would you do physical therapy? Now, there's some you might be able to do, because I know when I was dealing with the sciatic nerve, there was things that she could have just shown me how to do them, and I could have emulated that. But that's not all physical therapy. And so I guess where I want to figure out now, that's just kind of my summary. Is there anything major that someone feels that I left out of this? Because I may actually have my assistant, I told him he didn't have to take minutes on this today, but he might list those for us. I think that'll be a good base for us. Rochelle, you had a comment, I believe, Representative Bishop?
Yeah, I thought that was a good summary, and I certainly agreed with the points you made. I was only going to provide this, I think physical therapy is a good example. I was only going to provide this as a point of reference. The current law that's in place so in phase 1 on telemedicine says that, again, telemedicine is it's a modality. It's a delivery tool. It's not a specialty. And the standard that's in place right now is that you have to be able to provide the same standard of care. So there are things you cannot do by telemedicine. There are things that maybe 10 years from now or 5 years from now or 2 years from now you will be able to do. But right now, that's the threshold, is that you have to be able to deliver the same standard of care in order for that to be an appropriate modality. So, and I think that was a good example. You know, you can't do something, you can't palpate the stomach right now either, which is a part of a routine physical. So there's just certain things that can't be done. There's some things that can, but I think that's appropriate to allow both the technology and the medicine to evolve in a way that reflects standard of care. So that was just for information.
All right, Representative Bishop.
Thank you, Madam Chair. This may be something that was covered when we did consider the telehealth bill, but I don't recall it being discussed, and that is the federal end of things. What is the point of view from CMS, Medicare, and Medicaid? That is not always the best model, but it is a place to start.
Well, and I had actually, when I made my notes on all insurance not being equal, I had added Medicare and Medicaid because they are a big player in everything that we do out there. So was there someone else that had something to add? Oh, Representative Blex, I believe you did.
Thank you, Madam Chair, for a second time. One thing I was just thinking about that, you know, we've passed and discussed a lot of bills for mental health, 988. And, you know, in my simple mind, for the mental health providers, establishing a good telemedicine network is probably a form of that crisis team that we don't have to send out and we don't have to pay 50 cents a phone. Thank you.
We're going to have that discussion on what that cost factor is. And we won't go into that today. Representative Kelly.
Thank you, Madam Chair. I think you had an excellent summary. And I think some of the discussion that we had here in the last probably 10 minutes shows where everyone getting together outside of the legislature is the way to go, because you'd come back with recommendations on a teledoc Amwell platform versus in person, and you don't get caught up with kind of what can happen in a legislative process. So I think it'd be really good to continue it now, and then come back with a plan that's agreed to, as well as agreed to can be, by all parties, and that's a perfect starting place rather than us starting from ground up and building it the way you don't like. So I would encourage that, and I would encourage it to start happening as quickly as possible.
Are there further comments? I want to thank everyone that took time out of their day, and I know some of you had to travel further than others did, and I know that Bernard would have liked to have been here with us today, but his company's not allowing travel at this time, but we appreciated him joining us. I know that we had, Claudia, did you ever find a car to get you here from Kansas City?
I did not find a car. However, Uber runs both ways.
All right. Okay, so I mean, but I thank each and every one of you, because I also know that you all have very busy schedules, and we put this together kind of quick, but as the more I thought about it, and I just felt like we needed to get this discussion started, and I wanted the committee members to understand how complex this is, and my goal is, my desire is that all of you sitting here today and whoever the right individuals are at the table. So however you can organize those meetings, however you can get those meetings started, I think would be good. I don't believe that the legislature should be the ones that come in here and dictate the details of how this works. But as you go through the process and you find that there are things that the legislature needs to tweak, change in their law, or put in their laws, then we are, absolutely here to help you. But I can guarantee you that, and Rochelle's heard this many, many times, as has a few other people in this room, if you don't, the legislature will, and neither side will like it when we do. And I'm just convinced that this is something that the industries and the contractual people, as well as the the providers of services, can take and work out together. So whomever needs to take and organize that, and I think that the more insurance folks that can be involved, whether it's with the Medicaid side, the Medicare side, I don't know how you'd ever do anything with the ERISAs, but they're probably on their own. But, bringing this together, I think would really be great. So thank you from the bottom of my heart, and I know that my vice chair was looking forward to this meeting here today as well. So thank you. And committee, just keep your ears open. Right now, we think we're done, but we may not be. We still have next week if we do have bills that come before us. But currently, we are no committee tomorrow, no committee on Friday, and we're on the call of the chair as of Monday for all of next week. But please watch your emails from Dave and listen to me on the floor or Representative Epley if he goes down there.